Okay, so many people may wonder, what is pelvic floor physical therapy? So we, by nature, we hold physical therapy degrees, so I have my master's degree. It typically involves 4 years of undergrad, postgraduate training, which is now a doctorate level, which is 3 to 4 years. And to actually specialize in pelvic floor physical therapy, it's still something that isn't being taught in most of the curricula across the country. So when you encounter a pelvic floor physical therapist, there's somebody who's taken a lot of their own time, effort, and money to get trained to be able to treat this patient population. So most of the people that you will encounter are very passionate about it and excited to help in an area where I think we do have a lot of value. So to just break it down to start simply, we'll just go over a little bit of the pelvic floor anatomy. So here are 2 different diagrams of the male and female pelvic floor. Yes, men have pelvic floors too. I know many of us commonly think of pelvic floor issues with childbirth and things like that, and hopefully today's lecture is going to show you that there's a much more broad range that we can serve the community. So these muscles, as you can see here, run between the pubic bone and the tailbone. They're also known as the levator ani muscles, and they have pretty important roles in our bodies and our health. In addition to the muscles, there's also a wide range of innervation that goes to the pelvic floor. The most common and most vast nerve is the pudendal nerve. It's responsible for innervating all of the genitalia in men and women, plus the majority of the pelvic floor muscles, plus part of the urethra and part of the rectum. It's kind of a big deal. So when we look at the physiology of the pelvic floor, it's slightly different than every other part of the body. And the reason is because most of our regular skeletal muscles have sensory and motor function, meaning you can move the muscle and you can feel things. In the pelvic floor, there's also autonomic fibers, which means that part of the pelvic floor is under involuntary control. So just like your breath, you'll breathe without thinking about it, but you have the ability to either hold your breath or breathe faster if you so choose. Just like with your pelvic floor, these muscles are always active, which makes them a little bit more difficult to treat when things go awry. But you also, for example, could do a Kegel, or you relax your pelvic floor when you initiate your urine stream. If you don't think to do those things, these muscles under autonomic function will stay active to keep us continent and prevent unwanted accidents and things like that. They're also significantly involved in orgasm function and sexual health, which we'll talk about today. And it's also responsible for bladder and bowel control, and it also provides support for the organs of the pelvic cavity, which are the bladder, the prostate, the uterus, and the bowel. So as we talked about what do pelvic floor PTs actually do, we're actually involved in patients throughout the lifespan. So as early as childhood, where there are often issues with constipation, urinary incontinence, bedwetting, we do play a role in this population as well. And I just put in an example of the squattypotamus here, who was created by pediatric urologist Stephen Hodges. Most of our children who are constipated actually have difficulty because of bowel mechanics, same as adults. And actually helping them evacuate stool properly lessens their leaks. So as pelvic floor PTs, we're responsible for education, and even if we're treating adults, they usually have children, we can try to help with some of these things that really may not be as big as a catastrophe as they are made out to be. Okay, so we're going to talk about pelvic pain disorders today, and we're also going to talk about low-tone pelvic disorders, and they're quite different. We're going to talk about this in both sexes and transgender community. So when we're talking about pelvic pain, we're talking about the most common diagnosis: vulvodynia, vaginismus, interstitial cystitis, pudendal neuralgia, and endometriosis. There's another disorder called persistent genital arousal disorder. We're involved in pregnancy in the postpartum period, perimenopause and menopause, gynecological cancers and the side effects that come from some of the treatments, as well as pelvic floor reconstruction rehabilitation. So when we talk about the female sexual pain disorders, it's always good for people to kind of get a grasp as to what these things are. So vulvodynia is described as pain in the area of the vulva, which includes the interlabial area, the vulva itself, and the vestibule, which is this little ridge of tissue right here. I like this diagram because you can also see the muscles underneath of there in this exam. And all of these sexual pain and female pelvic pain disorders have a strong correlation, over 90%, with pelvic floor dysfunction. If it isn't the cause of it itself, it is always associated with these diagnoses. So vulvar pain can be caused by a number of different causes that have been well researched. And it wasn't until 2015 where vulvodynia became a diagnosis of known origin. Up until 2015, it was considered a diagnosis of unknown origin, which you can imagine the confusion that would create in the medical community. And it was challenging for those of us working in the field because we know that there's causes of vulvodynia, but it wasn't commonly accepted in the broad medical societies until just a few years ago. So some common causes of this can be infectious, it can be hormonal, it can be neoplastic, such as Paget's disease. There's neurologic causes, such as postherpetic neuralgia or pudendal neuralgia. It can happen as a result of trauma from female genital mutilation, childbirth. There can be iatrogenic causes, meaning it showed up in response to a treatment for another situation. And hormonal deficiencies is a big one because that happens in the perimenopause and menopause phase, but also is a leading cause of vulvodynia in young women in response to oral contraceptive birth control pills. So there's a big situation going on right now with that because right now women are not being counseled that taking oral contraceptives is a risk factor for vulvodynia. They are being talked about blood clots and other risk factors, but for some reason, conveniently, this one is being left off. It can be localized or generalized, and it can either be provoked by something such as intercourse, or it can be unprovoked, meaning people just have spontaneous and unprovoked pain. So to continue, and you can see here, when there is hormonal insufficiencies and various reasons why vulvodynia develops, you'll also see visual tissue changes. So I point this out because of the distinction between vulvodynia and vaginismus, which is next. But as you can see here, there's a lot of erythema in the vulva here as well, in these areas too. When there are these visual changes and they're hormonally induced, which is a large percentage of the people with vulvodynia, it's very important to treat the tissues and the hormonal insufficiencies as well as the pelvic floor dysfunction. And so as we're going to get into the talk today, you'll see that we overlap with a lot of other disciplines, and most of the treatment, especially for the pelvic pain disorders, is interdisciplinary. Oops. If you would like more information on this topic, please email me, and I published a paper that summarizes all of the research that was talked about in that 2015 conference. I distinguish the vulvar tissue from vaginismus because, especially in a psychological setting, these are probably two of the very common causes of painful sex that you will see with people, and they're very different. So vaginismus is described as a painful spasmodic contraction in the vagina in response to physical contact or pressure. Most of the patients with vaginismus do not have unprovoked pain, whereas in the patients with vulvodynia, they actually can. The reason I bring this up is because often patients may buy dilators or things online, because you'll see that that's what's told to be treatment for vaginismus. If they actually have vulvodynia, which could mimic vaginismus to the person who doesn't understand, and they're inserting a dilator on tissues that's fragile, they're just injuring themselves, hurting themselves, and causing psychological trauma from what they think they should be doing. So the differential diagnosis between these is important, as well as a comprehensive plan. Endometriosis is a disease where the endometrium actually grows outside of the uterus itself. This is a very painful condition that can affect 1 in 10 women. In some cases, it actually is not painful, but it can cause infertility. As people go through their normal monthly cycle, if endometrium is growing outside of the uterus, that means that it also thickens, sheds, and bleeds, causing intra-abdominal pain when that happens. It also is associated with superficial and deep dyspareunia. One of the reasons is because of the pain from a visceral structure, there's somatic consequences. When it occurs every month over and over again, people start to get muscle spasm and tightness in response to that, and now they have generators of the endometriosis itself, but also somatic and pelvic floor dysfunction. In addition to that, women who are suspected to have endometriosis are often immediately put on the birth control pill, which we now know causes vulvodynia. So in addition to having the muscle pain, the visceral pain, now they also may have vestibulodynia, also interfering with their ability to have sex. There's a high correlation between all of these syndromes. Endometriosis, interstitial cystitis, and pelvic floor dysfunction are coined the evil triplets together. Again, warranting the need for interdisciplinary care for these women. There have been protests in the United States recently and amazing movements by the endometriosis societies to get better diagnosis and treatment for women. Right now, the only way to diagnose endometriosis is through a surgical biopsy, which is something that you don't want to subject someone to who's been in pain. So there's been a lot of advocacy in the last 2 years, and I'm glad to see that the landscape is changing. Persistent genital arousal disorder is not common, but it is there. And so this is when people feel arousal in a non-contextual situation. They feel like they're on the edge of orgasm and they may be sitting in a classroom and completely not aroused at all. It's associated with both high-tone and low-tone pelvic floor disorders. It's suspected that this could be a hormone dysregulation issue and a possible central nervous system processing disorder. Okay, so interstitial cystitis, let's talk about that first, is a disease that was historically thought as a bladder disease, again, until recently. The disease is characterized by severe symptoms of urinary urgency and frequency, painful bladder filling, difficulty evacuating their urine, as well as pain upon urination. It was previously thought to be called what's called Hunter's lesions in the bladder itself, but all the studies that have been done in the last 10 to 20 years have actually confirmed that 90% of people with these symptoms have a pelvic floor disorder. And the majority of patients, only 3% of patients actually had lesions in their bladder themselves. So in some cases, it is a bladder issue, but in many cases, the bladder is the symptom and not the cause. Pudendal neuralgia is another diagnosis that I endearingly call carpal tunnel of the butt. If we remember where the pudendal nerve goes, it goes to your genitals, your clitoris, the penis, the perineum, the anus. When this nerve becomes involved, people feel sharp, shooting, stabbing pain anywhere in those territories. It can be provoked by mechanical things such as sitting or horseback riding, or it can be spontaneous. Also a myofascial pelvic floor disorder of high tone, obviously. So shifting gears a little bit, we also play a role in the peripartum period. You can see the muscles here. As we know, bodies undergo a tremendous amount of physiological, normal, healthy change when people advance in their pregnancies, but that also can come with musculoskeletal consequences. So we often treat women with pelvic girdle pain. They may have stress incontinence. We help women prepare for labor and delivery with the musculoskeletal health and concerns. We want to teach them how to control their pelvic floor muscles, set them up for success during labor and delivery. We can help by improving perineal elasticity, so there's less tearing. And we can help them with optimal birth positions, especially if they have other issues going on, such as pelvic girdle pain, low back pain, those types of issues. It's not a secret now that the United States is last in industrialized countries for postpartum care for women, and included in that is the reason that we are the only country that doesn't mandate pelvic floor physical therapy after delivery. Every other industrialized country does this. Interesting statistics have come out in the last few years that have led to change, but 71% of college-educated women were not aware that their pelvic floor muscles were involved in childbirth at all. 60% of postpartum women had stress incontinence. 25% of them still had pain during sex at a year and a half after, regardless of the method of delivery. And a high percentage, 64.3%, had female sexual dysfunction. This is for many reasons, but important is this: if you think about childbirth or a C-section, obviously you would need rehabilitation after that, compared to an ankle sprain or a shoulder or something much less complicated. But because of, again, movements across the country, just this year, the American College of Obstetrics and Gynecology has finally redesigned postpartum care for women, acknowledging that there should be a fourth trimester and that these women need more care than we've been giving them. So this was exciting for everybody, and included in the many things that are talked about from ACOG is the need for postpartum pelvic floor physical therapy after birth. That was exciting. Okay, so to switch gears a little bit and advancing in the lifespan, there's also involvement for us in the field of low-tone pelvic floor disorders. So this happens around perimenopause and menopause, where normal age-related changes may be resulting in muscle weakness. A lack of accurate and appropriate postpartum care also is the #1 risk factor for pelvic organ prolapse later in life. That is when the bladder, the urethra, the uterus start to descend into the vagina, sometimes out of the vagina. In other places where postpartum pelvic floor physical therapy is implemented, they have much lower rates of stress urinary incontinence and pelvic organ prolapse for people in the later years. There's a lot of hormone controversy right now about HRT and is it safe or not, and unfortunately the media did sensationalize it in 2002 when it was told it wasn't safe, and in fact that isn't true now, but a lot of women are very confused, and so they may come to pelvic floor physical therapy with a symptom or a complaint of painful sex. We often identify that it is hormonally related and work with doctors to help them safely treat the tissue as well as possibly the muscles if that is a cause of their issues. Again, this causes a lot of embarrassment for women, and a lot of times they just live with it. They may not even think to tell their doctor or their gynecologist that there is painful sex or they're leaking during sex or things like that. So we try to help release appropriate information about this time period. Associated comorbidities are overactive bladder, stress incontinence, prolapse. There can be hypodesire, pelvic pain, and constipation issues. So treatment in this group actually focuses on uptraining the pelvic floor. So this may be what you think of more commonly with pelvic floor physical therapy. We're going to be doing neuromuscular re-education, Kegel exercises may be part of it, things to make the people stronger. Whereas in the pelvic pain group, we're going to be doing a lot of down training and manual therapy, trying to make the muscles more relaxed. So there's a very significant difference between these two groups, and unfortunately, sometimes they all get lumped together in the medical community, painful sex and leaking, and the baby is said, just go do your Kegels. 80% of women with verbal instruction alone did not perform a Kegel properly, and a quarter of those women actually were doing the Kegels in a way that would make these types of issues worse. So at least one visit is warranted for proper exercise instruction if that's going to be part of a woman's plan. Okay, so let's switch gears a little bit to the gentlemen. Most people also don't realize that 10% of men have pelvic pain at some point in their life. It is almost always diagnosed as prostatitis incorrectly. There is no infection, yet they're always given Cipro and broad-spectrum antibiotics, and sometimes for multiple months at length, even though the infection and the cultures were negative. They also can develop interstitial cystitis and painful bladder syndrome and pudendal neuralgia, just like the ladies. Unfortunately, recently and on the rise, we're seeing a number of people who have undergone penile enhancement and foreskin regeneration procedures. There's various dangerous protocols that young men are reading online and basically causing damage to their organs to try to enhance the length or girth of their penis. We can help with erectile dysfunction that may or may not be associated with pain and neurologic disorders because of the pelvic floor muscles and the anatomy as you saw. Arteries, nerves, and veins run together. So if there's a muscle compression, it can also cause a blood flow issue on some of the arteries that are important for erectile dysfunction. If it is coming from a musculoskeletal cause, these young men may not respond to Viagra or Cialis, and often they have overlapping neurologic or pelvic pain symptoms. Often, before and after prostatectomy, utilizing physical therapy significantly reduces the percentage of men who have urinary incontinence as well as erectile dysfunction. Okay, so chronic pelvic pain syndrome is the most common diagnosis for male pelvic pain. Usually, again, there's urinary urgency, frequency, and hesitancy. They may feel pain in the perineum, at the tip of the penis, in the anus. They often have post-ejaculatory pain, meaning there can be burning or aching in the tip of the penis or any of the structures I just mentioned. They may have a lack of sensation. And again, similar to the high-tone pelvic floor disorders in women, focus for treatment is going to be on manual therapy and down training these areas. Okay, Okay, again, we're going to skip through that. And again, doing physical therapy uptraining and getting the men to have better neuromuscular control can help, again, preserve some of the erectile function and reduce stress incontinence after prostatectomy. The average numbers after, you can see, are high and varied with prostate surgeries. And again, these usually affect people in their 50s and will have a significant impact on their sexual life and overall quality of being. Okay, so we're going to get into actually what a physical therapy evaluation is and what we actually do in the treatment rooms with some different videos. So when we're first getting introduced to a patient, a few things can happen. Sometimes they find us online and they're pretty certain that they know what they have by the time they're coming. Sometimes they're referred by either a gynecologist, a urologist, colorectal, primary care. Our psychology groups also can refer patients over. And depending on how much they know coming in, the history is a really good time to assess what their knowledge is, what their beliefs are around their symptoms. We need to ask a number of questions to figure out how these symptoms developed, what they think happened. And that will include everything from how many times a day do you urinate? Do you have difficulty starting your stream? Does the stream hit one side of the leg or the other? Are you constipated? Do you have diarrhea? What is your sexual function? Have you been having difficulty orgasming? Have you never been able to orgasm? In many young women with high-tone pelvic floor disorders, it can begin as something like urinary frequency, and they go to become sexually active, and if their muscles are super tight, an orgasm is a rapid muscle contraction, they may not be able to actually orgasm because of hypertonicity. So a lot of times when we are seeing young female patients, they say, well, no, I've never been able to orgasm, and we track this back a little bit, and you can hear in their history that there's reasons. We also want to know about past effective and ineffective treatments. A lot of our patients have been ping-ponged around the medical community between different disciplines. They're on a number of medications, often not even at a therapeutic dose because they may not have gone back to that doctor. They don't know what they're taking or why they're taking it. And we have to kind of sift through all of that. We also want to know about other providers and who they've seen for this problem. Usually people come in with a fair amount of angst and frustration, mostly because they've been told it's in their head or their doctors didn't know, or they're being put on an antibiotic and they don't have an infection. All the number of things we kind of have to sift through during that first appointment. So then we get into the manual evaluation. So pelvic floor PT isn't the same type of exercise, big gym situation that you may think of the most. We're in private treatment rooms. We will examine the connective tissue from the ribs actually down to the knees, so everything in the abdomen and the trunk. The legs, we're looking for trigger points within the muscles of all of the external pelvic girdle muscles too, which basically just means like a little hyperirritable spot within the muscle belly itself. That can cause local pain, but it can also cause referred pain and referred dysfunction, such as things like urinary urgency and frequency, abdominal pain, difficulty with bowel movement. We also look at the biomechanics, which is going to be more important in some of our patients than others. If someone developed pudendal neuralgia because they were in a car accident, their knees hit the dashboard, that offset the biomechanics of their pelvis, that's going to be a more structural issue compared to a woman who has endometriosis and developed pudendal neuralgia after years of chronic pelvic floor muscle tightness. So everything's going to be a little bit different based on their history. That will help us guide what we do that first day during the exam. We also want to know about neuromuscular control. As I alluded to already, it's not just about the Kegel exercise for any of these patients, even if that may be part of the program. We really need the pelvic floor muscles to function with the rest of the core and the pelvic girdle, and we'll examine all of that in our patients. We do want to know if they're strong, what their endurance is. We will look at the transanal, transvaginal, so either through the vagina or through the anus, then we will examine the pelvic floor muscles. So we first look at the skin in these areas. There can be anal fissures, vulvar erythema, as we saw in the pictures. We examine the muscles for tenderness, but also tone. So you can have high tone muscles that aren't sore, especially if they've been chronically tightened for a long period of time. We need to see motor control. If I ask a patient to squeeze, can they do that? If I ask them to relax, can they do that? More often than not, most people cannot. And again, strength and endurance is important more in the low tone disorders than the high tone disorders. We'll find that in the high tone disorders, the muscles are tight, which makes them appear to be weak. So lengthening the muscles, once they're at a more normal length, can actually contract and generate a fair amount of force. They do not necessarily need to be strengthened, possibly at any point during the treatment plan. So we also screen for central sensitization, which has really been something that medical professionals have been talking about more in the last 5 years. We've gotten away from treating pain with opiates, which really was something all of our patients were on when I started my career in 2001. Now it's more about pain physiology education, explaining the difference between acute pain like a yeast infection versus persisting pain, which is 5 years of vulvodynia, and understanding that pain isn't damage and teaching people that we are going to help undo what has happened along the way. We have to evaluate, again, what they're thinking about their problem. When you Google any of the diagnoses that I have shown, it looks horrifying to patients. They see people in chat rooms that may have suffered for 15 to 20 years. They don't have help. They're on opiates. They've lost their jobs. They've lost their families. If you feel like you had some vulvar pain and then you read that before you talk to a medical provider who knew what was wrong with you, you're going to be terrified. And so a lot of the education that happens the first day is undoing these myths that are online. There is psychological consequences from persisting pain, and a number of our patients actually have been traumatized by going through the medical community in and of itself. I am horrified by some of the things that I hear that they've been told, and we have to work to undo that and also work with a really great group of interdisciplinary providers that understand and can help where we need them. And again, there's a lot of fear avoidance. Understandably, if you're in pain or if you're leaking stool, you're afraid to go out, you're afraid to do things. Sometimes this is self-imposed, sometimes it's not. So we need to get an idea as to what biopsychosocial factors are affecting the person with both their professional and their personal life. So the assessment is one of the most interesting parts of this entire process, I feel, because that's where we're really taking the history with our patients and the physical findings and linking it together with their symptoms and explaining why they can't sit down, why they can't have sex, what are the causes, how did this develop. So some causes of the high tone disorders, and again, whether it's labeled interstitial cystitis, vulvodynia, pudendal neuralgia, is much less important. That's just a descriptor as to where the pain is. It is not a protocol-generated field. So what we have to do is break it down into the impairments and what they have, and then develop the treatment plan. So these disorders can develop because of compression issues such as cycling or horseback riding. It can be from tension issues such as heavy weightlifting, deep squats. Chronic constipation is another example of a tension issue. Some of our patients have had, let's say they were on oral contraceptives, more likely to develop a UTI. They've been on several courses of antibiotics, culture-proven UTI, but now they have a yeast infection. Now they've had another yeast infection. Now they have vulvar pain without either of those things being present, and that's probably because the muscles are tight and the tissue's dysfunctional. So in that assessment, we're really tying together how they ended up in the position that they're in, and we establish short and long-term goals. This is very important for pelvic floor disorders because they're kind of confusing to people. Most people don't understand totally what the entire treatment plan is going to look like, so we like to have it in short, measured form. So when we say short-term goals, that's usually 6 to 8 visits. The length of time someone's in physical therapy can vary based on the severity of their condition and the duration that it's been there. So some patients are fortunate and we see them maybe within 2 months, but I also have patients who have had problems for 30 years. So it's going to be very different depending on that background. So examples of short-term goals would be over the next 6 visits, which usually occur once a week. We are afforded the opportunity to see patients for an hour, so typically once a week for an hour. We would like to reduce the high tone of the pelvic floor, so Susie stops going to the bathroom every 15 minutes. We take the impairment and make a specific little goal that we're hoping to change by reducing that impairment. Another example could be to reduce the trigger points in the piriformis muscles so the SI joint is less painful, or to normalize the connective tissue in the bony pelvis so there's less pain during sex. Those are the little impairments that we're trying to change over time, which will lead to long-term functional change. We want Susie to be able to have pain-free orgasmic intercourse as often as she wants to without consequence. We want Susie to urinate no more than 6 to 8 times in a 24-hour period and not get up at night at all. We would like Bobby to be able to have sexual contact maybe 3 or 4 times a day and not experience post-ejaculatory pain or urinary frequency. If people do have stress incontinence, we would like Martha to be able to sneeze, cough, and laugh and not leak urine. If people are constipated, we would like them to be able to evacuate stool in less than 10 minutes. So those types of functional things that are important to our patients, we then turn into goals and work with them over time. So if it's going to be a longer term process for people, meaning somebody who has had pain for 10 years, it may involve detoxing them off of opiates. It may involve pain management in terms of other interventions, as well as physical therapy. But every 6 to 8 weeks, we kind of want to reassess where we are, reset the goals, and make sure everything is moving forward in the right direction. As Doug mentioned earlier, we have written a book called Pelvic Pain Explained. If you'd like more information or a copy, please just email me. It's very important to help people understand how they got here to help them get better. And again, we have to help manage their cases, and thank goodness we're afforded an hour with the patients, because most medical providers at this point in time, it's under 5 minutes. And so one of the primary things that we are well positioned to do is help organize the rest of the medical team. We will summarize their findings in a detailed report, talk to the gynecologist, talk to the urologist to make sure everyone's on the same page. If they do need a medication, or if we want them to stop being given medications, these are the types of things we can handle. There's also a lot of comorbidities. As you can see, there's a lot of overlap among these different diagnoses. And again, psychological management, we work very closely with both pain psychologists and with sex therapists. One of the hardest things for some of our female patients is once they've had painful sex for a number of years and they start to get treated and it's no longer painful, it's a difficult transition sometimes to go from patient back to person. And so where our psychological colleagues have been very helpful is helping to deal with that and to deal with the trauma of having to go through this in the first place. It's still, in 2018, people are very embarrassed about these issues, and I wish they weren't, but they are. We need to try to help with that. So in addition to psychological management, we also promote mindfulness and stress reduction. This alone causes stress, and some people need different disciplines more than others. A lot of times people don't want to practice mindfulness because they say, I have a therapist for this 1 hour a week. So one of the other things we are well positioned to do in physical therapy is explain the difference between these two things, and also explain why additional psychological services may be necessary, and again, reduce the stigma associated with that. Weekly appointments, I had to work my dog into here somehow, so often the home exercise program, especially for high tone, will involve things like the foam roller. We will go through pain education every week. Again, as much as we talk, I still like people are very confused about what they're doing and why. We want to neutralize the fear, reduce the fear. We're going to show you videos of some of the manual therapy techniques that we use, and again, we go through neuromuscular re-education. So the dog really shouldn't come to work because he eats everything. And again, that's just, he's not part of our therapeutic process yet, but maybe in a few years he'll get there. Okay, so patient resources, as Doug mentioned, and I'm dating myself because I used to watch As the World Turns when I was younger. It was on in the house. We do write a weekly blog, As the Pelvis Turns, and you can see by the number of posts, these are all evidence-based and researched on the different categories. So our website is a good resource for patients, as well as our involvement with the various nonprofit medical societies that I'm on the board for. We do have access to a lot of their articles and videos and things as well, and those are all on our website. Okay, let's go to the videos. But before I go into those, I know I'm rushing because I was nervous about the hour. Does anybody have any questions?
Is your website listed on here?
Yes, it's pelvicpainrehab.com.
On that page?
Mm-hmm. Yes.
I know that being on birth control can cause some of these issues. When you stop birth control,
That's a great question.
like does the tissue return to normal? Or?
No. So on the topic of oral contraceptives, it was when you stop them, if they have had a vestibulodynia or vulvodynia induced, does it return to normal? In some cases, it does not, and that is the issue. So what the researchers have identified is some women have what they're calling a genetic mutation that will make them more likely to develop vestibulodynia in response to oral contraceptives. This is not available yet to the general public to test that, so we don't know who's who. And so in many cases, if there is OCP-induced vestibulodynia, physical therapy will help the secondary muscle spasm. And then often topical estrogen and testosterone is used on those tissues, as well as sometimes systemic testosterone support. What happens with oral contraceptives is it basically puts you into a semi-chemical menopause, and sometimes those levels don't come back. And so there are very good doctors, especially in LA, who have like pioneered some of this work, and it can then change. And unfortunately, in some of the cases, though, it does not. And so then there's possible surgical considerations about removing the painful tissue, and it's just been difficult to manage. So I'm very on the education campaign about the possible risks of these pills. Yes?
Coming to see you, oh, I know this from my patients, is it covered by insurance?
So that's a good question. It is covered by insurance, just like typical physical therapy. You will find that most pelvic floor physical therapists, my practices included, are out of network. So with that comes a super bill, and then whatever their out of network reimbursement rates are for physical therapy, it gets covered in that manner.
Only if they are allowed out of network.
Only if they're allowed out of network. So it must be a PPO. However, we often get letters of exception for HMO patients if there's no one in their network that can provide our services, and often there's not, then it can be covered by insurance, and so we'll work with letters of agreement and things like that.
What about Medicare?
We are not Medicare providers, and so unfortunately Medicare does not acknowledge some of these diagnoses as diagnoses, and as pelvic floor physical therapists, we're not allowed to opt out of Medicare because we're considered a service, not a person, and so therefore we're unable to work with Medicare recipients. But there are certain hospital-based programs that do. Mm-hmm.
So I was just going to ask, do you work at any hospitals, or is it only private?
We have 8 private clinics, so we, again, collaborate with the community, but our clinics are physical therapy owned and operated. Mm-hmm.
Any difference with the ring versus the pill because it's a local effect?
The ring has been said to be worse than oral contraceptives, and recently they've been, I mean, the primary recommended choice is the Mirena IUD because it doesn't have any systemic consequences.
But then there are hormonal IUDs too.
There are hormonal IUDs, but it doesn't influence the systemic hormone levels is the difference between them. But there's again issues with the IUD because obviously it's painful to get that put in, and they're recently talking about different anesthesia approaches to help make that less terrible. Well, certain women, especially those who have had pelvic pain,
Well, yes,
are
in that population.
yes.
But in general, I mean, they make people get more scared than they need to be.
It is.
My
It sounds
patients say, I can't believe that's all I read, but this was not.
as bad as they thought.
they're
Yeah.
all mess. I was asking about the ring because I have patients who tell me that they notice vaginal changes when they use the ring, and it's in both directions.
Mhm.
Some say I have more discharge,
Mhm.
lubrication, and others say I feel dry. So I was wondering if you were seeing a difference between those.
And it depends too on their age and other factors and the health of their tissues going into the ring. Mm-hmm. Okay, any other questions?
Well, I was thinking about some of my clients that are young women who do not orgasm.
Mm-hmm.
And well, the 3 I'm thinking of are seemingly healthy, and they do yoga, and I'm thinking I'm going to recommend, I don't know if they can or not, financially or insurance. Well, one of them I'm pretty sure can. But so none of them have trauma either, because I also work with sexual trauma and things like that. So do I just say call you, or do I
Yep. So with this, especially this situation, it's like I think you haven't thought about physical therapy before. So what I would suggest is just letting them know that sometimes people cannot orgasm because of muscle dysfunction, and asking a few other questions may help of things they maybe didn't think to tell you, like they do have painful periods. I'm assuming they would have mentioned if they have pain with sex or not. If they urinate more than 6 to 8 times in a 24-hour period, that's usually a sign of a high tone disorder, or if they're constipated, they may also have neuromuscular control issues. So typically with women who have difficulty orgasming, we will be able to figure this out pretty quickly, especially if they do not have pain. During the first evaluation, we'll be able to figure out if there's muscle impairments or not. So by the end of that hour, they'll have an idea if we can help them or not. If we can't, we can't, but we'll know that quickly.
One of them is pregnant.
Mm-hmm.
I'm thinking it would be great for her to see you.
We love the pregnant ladies. I know, as you can see, we see such a variety of things in the clinic that sometimes it's nice to see the postpartum woman who is just like, can you help my birth be easier? Yes. Yes, it's a different situation than somebody with 15 years of pain.
So the urinating and the constipation, we actually do talk a little bit about things like that, but some of those things I have not asked. So
We're happy to help. Yeah.
It sounds like from what you said that there was a little bit more of a protocol now for Vulvodynia, which was all over the place
Mm-hmm.
for many years. So, and I haven't kept up with it as much. Is it true that there's a little, I mean, we were all kinds of different.
Yes, no, I know.
Estrogen has always been one, but it sounds
Yeah.
like there's more of a standardized.
Yes, and
Obviously nothing's totally standard when it comes to pain, but.
when I was very involved with the Vulvodynia Nomenclature Consensus Conference, I was one of the 30 experts that had to review all the literature, and then we had to come up with the protocols and guidelines. And so I feel very passionate about Vulvodynia because it is treatable. And I mean, previously it didn't look like it was. But you can see why some treatment plans fail. If they were using dilators on these tissues, and everybody was given dilators at one point for Vulvodynia, it was not the right thing to do. And so this information is working its way into ACOG and these other large societies. But a lot of the research is in these smaller societies, like the International Pelvic Pain Society and ISHWISH. So it's pockets of people across the country know a tremendous amount, and then there's a whole variance in between. But there is a lot that these women can do and completely resolve their issues as well.
So
Yeah.
that a couple of years ago, I think I was researching Kegels and stuff, and something came up with something something that women can buy at $1,000, and I don't know, stimulates. You know
Yes.
what I'm talking
So there's a number of devices on the market now. That was probably, it sounds like if it was making them contract an electrical stimulation, not recommended and contraindicated for pelvic pain. But if there is motor loss from pregnancy, from age-related changes, that can help force a muscle contraction if they're not able to access it themselves, which can actually be helpful in certain cases. The problem is again, a lot of the things that are used for incontinence may get in the hands of somebody for pain, and it shouldn't be, because they just think that that's what you should do.
Not like Thermiva and Mona Lisa.
I love them. Yes.
Do you know about VFit also?
I don't know about VFit. So the Mona Lisa and Thermiva are laser resurfacing things that have actually been used in Vulvodynia patients with success as well. Yes, and so for especially women who can't, for medical reasons, tolerate hormones and things like that, these are a way that can help make those tissues robust, less sensitive, less painful. Unfortunately, again, those procedures aren't covered by insurance.
And it's $3,500.
I work with people where it's 22 to 24, so yes.
So there's
Yes.
a new one that's not as good for severe problems, but to mild to moderate or for maintenance between the yearly when they're done. And it's a home one that just.
A home unit, oh, that's interesting. Yeah. Well, thank you, especially
Thank you. That's-
on a Friday in July. Yes, I appreciate your time. Thank you. Thank you.